I request Dr. Bindu to speak to us on the very important aspect of MIGS, that is how to do intraoperative gonioscopy.
Good afternoon. Like what Ganesh sir told, the first thing what we have to learn is to do an intraoperative gonioscopy before we convert ourselves to MIGS surgery. So the first person to see the angle was in a keratoglobus, and then we all know the principle behind the difficulty in viewing the angle is the total internal reflection. Then all types of gonio lenses came in, and now we are with the research of MIGS. This topic has become very important. And now we go on to the direct gonio lenses, which help us to view the angles when you are going to do the angle surgery. Of late, we have many more coming. Initially, it was a Shan-Jacob lens, then the KSOS surgical lenses, the ocular Hill surgical gonioprism. You have the Hoskin-Barkins, the hands-free lenses. The newer ones are the Glaucos eye prism and the KSOS hand-free gonioprisms. Now, what is the prerequisites for a direct gonioscopy? You need to select the patient, otherwise we end up in trouble. You have to have a patient who has a neck mobility, you have to have a cooperative patient with no head tremor, and also you should be able to visualize the angle before the surgery. And the most importantly, how do you prepare yourself? You have to know the anatomy very well and then practice it before you go into the doing the procedure of MIGS. Practice the gonioscopy and know your lenses. And then do we do it under topical or anesthesia? You could do topical, but then you have to be in the early stages at least. You can do it under block because even small involuntary eye movements can end up in complications. The first and foremost is how to prepare your microscope and your seating arrangements before you have to do. You just have to tilt the microscope 30 to 40 degree towards you and make the patients move 30 to 45 degree away from you and ask the patient to look away from you and adjust the microscope so that the light falls. And then you have to up the eyepiece so that you don't have to stoop forward and you don't injure your neck in that. And then be comfortable with the XY coupling because you have to do zoom in and zoom out many more times than in your phaco. And when you're sitting also, you have to sit a little bit away so that you can move your hands freely then. Some people mark it prior so that this much bend will be, they make it ideal so that the next time they keep another surgery, already they can go to the pre-marked thing. But it is not always the same. You can customize it many times you do, and then you know how much to bend and all that. This is what the sitting position. Phaco, you keep your hands close to you, but here you have to have some space so that you can move your hands also. So the ultimate is the line the coaxial light parallel to the iris plane, then increase the magnification, increase the light intensity to view the structures. Then comes now which gonio lens to select. The Shan-Jacob was the most commonly used one. It is reusable. Then you have the Glaucos eye prism with an expanded field of view. And as I mentioned earlier, the hands-free Coryza lenses. We also have the costlier ones, the TVG lenses. And then before we start the procedure, we have to dock the gonio lenses. You know, the cornea is highly innervated structure and then it can induce pain. So, either you give a paracaine drops or you can do it under block. And then I'll just show you a video. Is it running? Yes. This is the process of tilting the microscope, preparing yourself. Tilt the head of the patient away from you and also ask the patient to look away. Then you fill the anterior chamber with cohesive viscoelastic. And then put the visco over the cornea. And then you keep the gonio lens with your non-dominant hand. And then finally adjust to view the angle. You can zoom in and zoom out till you have a clear view. What we want is an end-face view where the angles are looking at you. It becomes easier to visualize and also during doing the procedure. This is the eye prism with a wider view. So what we don't want is a steep angle view where you keep your lens more anterior, and it becomes difficult, not only difficult in visualization, also difficult when you're doing a procedure and introducing the instrument to do the procedure. So that is the difficulty you have. You can't properly focus and you can't properly do it also if you have a steep angle view. Now, other difficulties that we face is, especially when blood comes under the gonial lens, the view gets obscured. And here, what we have to do as a phacosurgeon is make your incision more clear corneal. And during initial stages, we tend to put a lot of pressures and you get corneal folds, and then just release it and readjust, and you get a view. And sometimes even air gets under the lens and you have difficulty in visualizing the angle. The most important thing is you have to know your anatomy to identify what you're seeing. The blood in Schlem's canal and the pigmentation of the trabeculum helps you to identify the trabecular meshwork. Oh, sorry. The first, the best advice is after all your phaco surgeries, start doing gonioscopy. Repeat it and keep on repeating till you are confidently seeing the angle. And then what you have to do is, with a long instrument like an iris forceps, iris repositor, just go and touch the angles. So you can get used to have the two hands with the non-dominant hand holding the lens, and the dominant hand you can go in with your second instrument, have a feel of it, be comfortable with that, and then go on to procedures like the bang and the KDB, which Satyan sir will be teaching us. Thank you so much.
Thank you, Dr. Bindu.